Thank you, and a special thanks to Courtney for the last-minute invitation to present today, and to SAGES for including this session on DEI, although I will share the sentiments of many others previously that it would have been nice to see a few more folks here. I have nothing to disclose. In 1984, the Secretary of Health and Human Services, Margaret Heckler, commissioned the first formal federal investigation of health disparities of minorities, including Blacks, Asian Pacific Islanders, Hispanics, and Native Americans. This task force identified 6 causes of death that together accounted for more than 80% of the mortality observed among Blacks and other minority groups in the US, in excess of that of the white population. The resulting 239-page document inspired the creation of the Office of Minority Health in 1987, and in 1999, Congress mandated an annual National Healthcare Disparities Report and requested the Institute of Medicine assess the factors that contribute to these disparities. I'll get back to this later. The conversation of health equity has evolved over time, and I would like to briefly take a step back and first set the foundation for this topic with a few definitions. First, implicit bias. The Merriam-Webster Dictionary defines implicit bias as a bias that is present but not consciously held or recognized. This results in unconscious negative attitudes or discrimination towards others, and positive attitudes or beliefs about those for whom or with whom individuals self-identify. I'm sure many of you have heard of or even participated in Project Implicit, established through Harvard University in 1998. Anyone can visit their website and take a series of duality tests that, for better or for worse, bring to light our own implicit biases. These myriad tests include not only race, such as white versus Black, Asian, and Native American, but also gay-straight, ageism, gender career associations, and weight bias. Next, another set of words commonly used in this space: disparity, equality, fairness, and noncompliance. Interestingly, the AMA and AAMC Center for Health Justice recently published a guide to language, narrative, and concepts that challenges the use of these words and promotes more equity-focused, person-first language in its place. While disparity implies differences to economic, social, and/or environmental disadvantages, inequity contextualizes these differences as avoidable, unnecessary, and unjust. Equality is defined by treating everyone the same and is limited to providing the same amount and type of resources to an individual or population. For example, giving the same printed discharge paperwork to a blind individual as you would someone with perfect vision. This fails to take into account baseline demographic differences and historical narratives of disinvestment, discrimination, systemic oppression, slavery, ethnocide, the benefits of intergenerational wealth, etc. The list goes on. Equity, on the other hand, provides the resources to bridge this gap. The typical notion of fairness falls into these same biases. Fairness tends to describe equal allocation of resources of benefits, but does not ensure equal outcome. For example, assigning both parties in a trial to a lawyer is fair. However, how the system favors one party over the other, or how wealth and other external factors known to contribute to these outcomes is ignored. Social justice, rather, is more expansive and rooted in a standard of achieving rightness. The last shift in dialogue we're challenged to make is that of non-compliance versus non-adherence. Compliance is suggestive of simply whether a patient follows instructions or not. Non-compliance, therefore, places blame for failed treatment on the patient. Adherence brings the process into the picture, removing the sole responsibility of the outcome from the individual, recognizing non-adherence can be impacted by frustration or mistrust in the healthcare system, structural barriers that limit availability and accessibility, including cost, insurance, pharmacy deserts, and time and resource constraints such as family and work dynamics, not to mention failed communication from us, the providers. The U.S. DHHS and Office of Disease Prevention and Health Promotion's Healthy People Initiative 2020 defined health disparities as differences in health closely linked with economic, social, or environmental disadvantages that result in adverse effects on groups of people who have been marginalized. These conversations bring us to the social determinants of health. As defined by the World Health Organization, these are conditions in which people are born, grow, live, work, and age. These are shaped by the distribution of money, power, and resources, and underlie the notion of inequity as discussed earlier. The Healthy People 2030 initiative breaks down social determinants of health into 5 categories: health and health care, which includes access to primary care, health insurance coverage, and health literacy; social and community contexts, such as cohesion, civic participation, discrimination, workplace conditions, and incarceration; education above a high school level, language, literacy, and early childhood development; economic stability, including poverty, employment, and food security; and the neighborhood and built environment, including crime, housing, access to transportation, and air, water, and food quality. These are the key drivers in health inequities that increase the risk for poor health outcomes. Reducing and eliminating these disparities is essential to achieving health equity. The Institute of Medicine published Unequal Treatment in 2002, which included the observation that there are differences in quality of healthcare across our population that are not due to access, preferences, clinical needs, or appropriateness of intervention. It recommends areas for improvement in medical care financing, allocation, availability of language translation, community-based care, cross-cultural learning, and data collection and research initiatives. Subsequent research has corroborated that affordability, including not only out-of-pocket expenses, but indirect costs such as time off from work and transportation, still do not fully explain disparities in access to care. For instance, when payment for dialysis and kidney transplantation became covered by Medicare, equitable outcomes for patients with end-stage renal disease was still not seen. It has also been well established that health and healthcare inequities are especially pronounced in cardiovascular diseases and cancer, the 2 leading causes of death in the United States. But how does this translate into what we do? Well, in bariatric surgery, MBS QIP data from 2015 evaluated just over 108,000 patients and found significantly longer hospital length of stay and higher rates of readmission after both laparoscopic Roux-en-Y gastric bypass and sleeve gastrectomy in Black patients compared to whites. Additionally, Black patients undergoing sleeve gastrectomy were found to have significantly higher 30-day reoperation and mortality rates compared to whites. In colorectal surgery, a meta-analysis published online just last month, including 16 studies in over 1.1 million patients, demonstrated Black patients were less likely to receive surgery, less likely to undergo minimally invasive surgery when they did, and were twice as likely to refuse surgery when compared to white patients. 10 years of recent national Medicare data was reviewed from January 2007 to November 2016, evaluating the change in time of outcomes between white and Black patients after over 870,000 cancer operations. Fortunately, the study did show overall improvement in cancer surgery-specific mortality rates in both groups. However, the gap between white and Black patients did not budge. Reframing some of these outcomes can also shed light on how we seek to improve. For example, in vascular surgery, living in a food desert was associated with worse outcomes following revascularization for chronic limb-threatening ischemia. The USDA defines food deserts as geographic areas where over 1/3 of patients are greater than 1 mile in urban or 10 miles in rural areas away from the nearest supermarket, supercenter, or large grocery store. In communities with poor or no access to fresh produce, low-fat dairy, whole grains, and other healthy food options, populations may be more likely to suffer from high rates of diabetes, cardiovascular disease, and obesity, which impact outcomes. And in this study, such a phenomenon was found to be independent of income. This group looked at hospitalizations for Medicare patients aged 65 to 99 undergoing CABG, AAA repair, or resection of lung cancer from 2005 to 2008. They ranked hospitals by quality quintiles, examining the geographic proximity of Black and white patients in miles to these hospitals, and assigned dissimilarity index scores to the geographic area based on the degree of segregation. They found that Black patients were more likely to undergo surgery in low-quality hospitals and less likely to undergo surgery at high-quality hospitals for all 3 procedures, and that this phenomenon could not be explained by lack of geographic proximity. In fact, Black patients lived closer to average or high-quality hospitals than did their white counterparts. There was, however, a strong relationship between residential racial segregation and the use of low-quality hospitals. Could this represent referral patterns, patients seeking physicians with whom they identify, or systemic biases in high-quality hospitals and their physicians that either intentionally or subconsciously discriminate against Black patients? The WHO has identified 4 areas of intervention. 1, reduce inequalities in the distribution of socioeconomic factors of structural determinants like income and education, i.e., address poverty. 2, intervene at the level of intermediary determinants that mediate the effect of socioeconomic positions on health, such as smoking or working conditions. 3, address the reverse effects of health status on socioeconomic positions. If bad health leads to worsening of one's financial situation, can we find strategies to maintain people with chronic illness within the workforce? And 4, deliver curative healthcare in equitable ways. This may include offering people from lower socioeconomic positions extra healthcare in order to achieve the same effects as those in higher socioeconomic positions, a novel idea that we do not practice. So what do we do now? First, we change the questions we ask. The AMA Advancing Health Equity Guide to Language, Narrative, and Concepts also includes these examples of how we can reframe our perspective in addressing how we approach equitable care for our patients every day. Second, change the way we talk. The CDC actually provides guidelines for inclusive communication, which includes avoiding use of certain adjectives, indicating vulnerability, and dehumanizing language. For example, instead of saying diabetics, say persons with diabetes, or instead of saying the homeless, say people who are experiencing homelessness. You'd be surprised how this can adjust our attitudes. Additionally, remember there are many types of subpopulations, including people from racial and ethnic minorities, people from sexual, gender, and religious minority groups, and people with various disabilities. And finally, avoid violent or combative vernacular, and avoid unintentional blaming. Rather than saying, people who do not seek health care, try those with limited access to fill in the blank. Third, change the system. According to a 2018 report from the AAMC, when healthcare providers have life experiences that more closely matches that of their patients, the latter tend to be more satisfied with their care and adhere to medical advice. This effect has been seen in studies addressing racial, ethnic, and sexual minorities, as well as those with disabilities. Increasing diversity will thus improve access and adherence of underrepresented populations, will increase the use of healthcare through greater trust in the system, and may improve outcomes through better leadership and advocacy, translating to policies and programs aimed at serving these underrepresented populations. To get there, we also have to increase representation amongst trainees. In July 2019, the ACMG included an annual assessment requirement for residency and fellowship programs to include their efforts in recruiting and retaining a diverse workforce. Be honest during these. Additionally, when planning our approach to systemic change, we need to address all 4 levels of influence, including the individual, the community, the provider and organization, and the policies. In the interest of time, I'm not going to review all of the critical gaps frequently encountered during these processes, but to highlight a few. At the individual level, we must better include outcomes and social determinants of health among less well-studied populations, such as American Indians or Alaska Natives, rural residents, refugees, and immigrants. At level 2, we need to do better across addressing cultural differences in family decision-making and make use of these social network dynamics in approaching intervention. At level 3, we need to research and address not only prevention, care, and hospitalization, but post-discharge factors and physician cultural competence. And policies should do more to bridge the gap between the healthcare facilities and the communities they serve. And 4, change the way we teach. Start them young. This curriculum from Wake Forest begins with a 2-day health equity simulation during orientation, followed by a series of modules combining didactic training with experiential learning. It was implemented over a 3-year period for this study from 2008 to 2010 and assessed medical students' self-reported competence and confidence working with underserved populations. This approach paired one social determinant of health, which each of the required medical student clerkships, and those with diamonds partnered with nearby community organizations to create experiential learning activities such as delivering meals in low-income neighborhoods. This dedicated health equity curriculum was associated with significant improvement in students' self-reported knowledge of social determinants of health and confidence in working with underserved populations. I know that was a whirlwind, but the ideas here are just a few of many stepping stones that we can use to ensure health equity and optimize outcomes for the many underrepresented populations we care for, many of whom weren't even addressed in this talk today. Thank you.